Welcome to the audio digest of the American Journal of Psychiatry. I'm Dr. Susan Schultz with highlights for August 2010. This month, our topics include two-phase psychotherapy for PTSD related to childhood abuse, rapid versus gradual discontinuation of antidepressants, and augmentation of antidepressants with SAMe, S-adenosylmethionine. We've also got an article on endogenous opioid function in borderline personality disorder, which has been selected as meriting CME for readers who've subscribed to the AJP CME course program. Each month, brief companion exams are created for 3 of the most influential articles from each issue. By reading the articles and completing the online exam, individuals can earn up to 1 AMA PRA Category 1 credit per article. This activity is sponsored by the American Psychiatric Association. To subscribe, click on the CME link at our homepage, ajp.psychiatryonline.org. And there's lots more in the August issue. The Clinical Case Conference covers bipolar disorder and pregnancy, an important issue for clinicians. We've also got a review article on an exciting topic in genetics, copy number variations in schizophrenia. In addition to differences in DNA sequence between individuals, there are variations in the structure of the genome. Several million base pairs of DNA sequence may be lost or gained, and these may account for upward of 5% of the human genome. Our review gives you an introduction to the topic and a summary of the research on copy number variations in schizophrenia. Our audio highlights will begin with the randomized controlled trial of treatment for post-traumatic stress disorder related to childhood abuse. Mère-Hélène Cloutry and colleagues focused on emotional dysregulation and interpersonal difficulties, which are typical in these patients. Cognitive behavioral therapies don't explicitly address them, and most clinicians don't often use exposure therapy, since patients may have a hard time managing feelings that emerge from processing traumatic memories. One possibility is to strengthen day-to-day life competencies before exploring the past. A two-phase treatment was developed in which standardized exposure therapy is preceded by what's called skills training in affect and interpersonal regulation, or STAIR. In this study, STAIR followed by exposure was compared with 2 other treatments that substituted supported counseling for one phase in the experimental treatment, either STAIR or exposure. The participants were more than 100 women with DSM diagnoses of PTSD. In each case, it was related to sexual and/or physical abuse before the age of 18 by a caretaker or a person in authority. The experimental treatment, STAIR plus exposure, comprised 16 weekly sessions, 8 sessions for the skills training and 8 for the exposure. The skills training was adapted from dialectical behavior therapy. The first 4 sessions concentrated on regulating emotions, identifying and labeling feelings, managing emotions, tolerating distress, and accepting feelings and positive emotions. The next 4 sessions worked on interpersonal problems, and they focused on exploration and revision of maladaptive schemas, effective assertiveness, awareness of social context, and flexibility in interpersonal expectations and behaviors. In the exposure phase, the usual protocol was modified for these patients. The in vivo exposure to traumatic stimuli was replaced by practice of interpersonal skills. In addition, meaning analysis was introduced after the exposure. The exposure included narratives of both childhood and adult traumas, and after they were presented, schemas related to abuse were identified and evaluated. One of the control groups received the same skills training in the first 8 weeks, but then got only supportive counseling during the next phase. The other control group got supportive counseling in the first 8 weeks and then received the exposure therapy in the second 8 weeks. the supportive counseling was a client-directed discussion of life problems related to the patient's abuse history. Skills training and discussion of trauma memories were excluded. At the end of treatment, the proportion of patients without a PTSD diagnosis was highest for the patients who received both stare and exposure therapy, but it didn't differ significantly among the three groups. However, at 6 months, the difference in the proportion of patients without a diagnosis was significant. 55% for stare plus exposure, 37% for stare plus support, and 21% for support plus exposure. Full remission was defined as a score under 20 on the clinician-administered PTSD scale. The rates of full remission at 6 months ranged from 24% for stare plus exposure to 0% for support plus exposure. In addition, the patients who got both treatment phases continued to have reductions in PTSD symptoms between the end of treatment and 6 months, but the other two groups didn't. The two-phase treatment also led to greater reductions in problems with emotion regulation, anger expression, anxiety, and interpersonal problems. The dropout rate for the group receiving both treatments was similar to the rate for stare plus support, and it was lower than the rate for support plus exposure. Patients with borderline personality disorder also have problems in emotion processing. These often manifest as affective lability and impulse behaviors, including aggression and self-harm. The endogenous opioid system and mu-opioid receptors have long been implicated in the control of emotions and stress responses, and now Alan Prosson and colleagues report that they found dysregulation of regional endogenous opioid function in borderline personality disorder. Borderline patients differed significantly from healthy subjects in regional availability of mu-opioid receptors and in the response of the endogenous opioid system to an emotional challenge. The authors used positron emission tomography with a radiotracer selected for mu-opioid receptors. They examined the availability of the receptors in a neutral situation and after induction of sadness. Receptor availability was measured as non-displaceable binding potential. In the context of a challenge, reductions in binding potential may reflect activation of neurotransmission mediated by mu-opioid receptors. Increases in binding potential would reflect deactivation of neurotransmission. The study participants were 18 women with borderline personality disorder and matched comparison subjects. To induce sadness, they recalled a past autobiographical vignette that they associated with sadness. Non-displaceable binding potential was measured from PET scans during both the neutral and sad states. In the neutral state, the women with borderline personality disorder had significantly greater mu-opioid binding potential bilaterally in the orbitofrontal cortex, caudate nucleus, and nucleus accumbens, and in the left amygdala. This greater receptor availability could be due to lower baseline neurotransmitter tone. There was also one finding of significantly less binding potential in the borderline women that was in the posterior thalamus bilaterally. During induced sadness, the borderline women had greater activation of the endogenous opioid system than the comparison subjects in several regions, including the pregenual anterior cingulate, left orbitofrontal cortex, left ventral pallidum, and the left amygdala. These regions are highly interconnected, and in healthy volunteers, they're implicated in decision-making and in evaluating and responding to salient stimuli. Greater activation in the borderline patients also occurred in the left inferior temporal cortex. The patients with borderline personality disorder also had greater deactivation of mu-opioid neurotransmission in the nucleus accumbens, the hippocampus and parahippocampus, and the hypothalamus. The nucleus accumbens is implicated in the assignment of salience to both positive and negative events. The hippocampus and parahippocampus have roles in explicit memory encoding and retrieval. In addition, through hypothalamic connections, they're also involved in regulating the autonomic nervous and neuroendocrine systems. The brain regions where the patients had greater availability of mu-opioid receptors during the neutral state largely overlapped with those showing greater activation of the endogenous opioid system during sadness. In their editorial, Antonia New and Barbara Stanley demonstrate how these empirical findings may help explain the symptoms and etiology of borderline personality disorder. Until now, the role of opioids in this disorder was largely theoretical, but the new data may shed light on three common behavioral characteristics: self-cutting, substance abuse, and social dysfunction. For decades, researchers have conjectured that self-cutting is related to abnormalities in opioid activity. Patients with borderline personality disorder report that they engage in self-cutting not as a suicidal act, but as a means to relieve psychic pain. Many patients say that they don't feel physical pain when they cut themselves. Instead, cutting brings relief or a feeling of well-being. One view of this phenomenon is that it's a method of endogenous opioid generation. In this view, patients learn to cut themselves, thereby releasing opioids, which reward their behavior. There's also evidence that patients with borderline personality disorder who don't cut themselves are less symptomatic than those who do. These two factors led to efforts to treat borderline personality disorder with opiate antagonists to eliminate the positive feedback from cutting. Pilot studies had mixed results. Overall, the opiate antagonists may have slightly decreased cutting behavior, but they didn't improve the intrapsychic distress that leads to the cutting. This lack of reduction in distress is consistent with the model of opioid deficiency. So patients with borderline personality disorder and cutting behavior may have a pre-existing deficit in endogenous opioids. This would be consistent with the high rate of opiate abuse in these patients. And not only is there a high rate of opiate abuse in borderline personality disorder, there's also a high rate of borderline personality disorder among patients seeking treatment for substance abuse. It's been reported that 44% of individuals seeking buprenorphine treatment have borderline personality disorder. And clinically, it's been noted that people with borderline personality disorder who take opiates report feeling euthymic rather than euphoric, and that during withdrawal, these individuals have feelings of dysphoria. An opioid-deficient theory of borderline personality disorder might explain far more than self-injurious behavior. For example, the extraordinary difficulties of these patients in social behavior may also be linked to a deficit in endogenous opioids. The endogenous opioid system not only regulates pain, but also has an important role in social behavior. This system, through mu-opioid receptors, has long been implicated in regulation of emotional and stress responses. Reductions in its function have been associated with attachment behavior deficits and anxiety-like responses in animal models. In many species, the soothing and comforting that infants receive from maternal grooming and touching is mediated through the opioid system. In human beings, opioids are involved in normal and pathological emotion regulation, in addition to modulation of the sensory and affective dimensions of pain. Gunderson has argued for a greater focus on interpersonal dysfunction in understanding borderline personality disorder. He stated that the characteristic relational style offers the best discriminators for the diagnosis of borderline personality disorder. Mood shifts and self-destructive behaviors in borderline personality disorder seem to arise specifically in response to interpersonal triggers. Now we'll take a look at the two articles on antidepressants. First, Ross Baldessarini and colleagues report on illness risk following rapid versus gradual discontinuation of antidepressants. Previously, they showed that rapid discontinuation of lithium in bipolar disorder and antipsychotics in psychotic disorders reduced the length of time before the next episode of illness. The study of antidepressants was done with the large database assembled over the past 3 decades. Nearly 400 patients had stopped taking their antidepressant after successful treatment and were included in the analysis. More than half had recurrent major depressive disorder, and the rest had diagnoses of panic, bipolar II, or bipolar I disorder. Reflecting the long time span covered by the database, more than 200 patients were taking tricyclic or similar antidepressants. Some patients were also taking mood stabilizers, which were not discontinued. The patients who stopped taking antidepressants fell into 2 categories: those who stopped quickly, over 1 to 7 days, and those who did so gradually, over 2 or more weeks. The study group included only the patients who remained clinically stable for at least a week after discontinuation, and they were followed for at least a year. The median latency to new illness was about 3.5 months with rapid discontinuation, but more than 8 months with gradual discontinuation. The association between shorter latency and rapid discontinuation even remained with multivariate analysis to adjust for potentially relevant covariates. Remarkably, the latency after rapid discontinuation was 1/4 the average interval between previous episodes in the same patients. Numerous covariates related to illness severity and treatment showed no effect on illness latency. For instance, it wasn't related to duration of treatment or dose. There were effects, however, from the type of antidepressant and drug elimination half-life. Overall, latency was shorter for modern antidepressants than for tricyclics, and it was also less for drugs with shorter half-lives. However, these effects varied according to the pace of discontinuation. Latency after rapid discontinuation differed by less than 1 week between tricyclics and modern agents, whereas latency following gradual discontinuation was 5 months longer for tricyclics or tetracyclics than for modern antidepressants. Also, the effect of discontinuation pace was greater for drugs with relatively short elimination half-lives. Latency after rapid discontinuation was only 2 to 3 months for both drug classes and both elimination rates, and so the efficacy of gradual dose tapering may be greater for older agents and those with short half-lives. However, physiologic reactions to discontinuation also need to be considered, since they're strongly associated with modern serotonergic agents, particularly those with short half-lives. The differences in illness latency also varied somewhat by diagnosis. Among patients with bipolar I and panic disorder, the differences in latency between rapid and gradual discontinuation were larger than among patients with bipolar II disorder or recurrent major depressive disorder. In the study by Baldessarini and colleagues, the antidepressants were discontinued only after successful treatment. However, many depressed patients are still symptomatic after treatment, and so George Papakostas and colleagues tested S-adenosylmethionine, or SAMI, as an adjunct for patients with major depressive disorder who didn't respond to serotonin reuptake inhibitors. SAMI is approved as an antidepressant in Europe, but in the U.S. it's only available as an over-the-counter dietary supplement. SAMI is a naturally occurring molecule that serves as a methyl donor in human cellular metabolism. It's found throughout the body with particularly high concentrations in the liver, adrenal glands, and pineal gland. It also appears to be uniformly distributed in the brain, where it serves as a methyl donor in a variety of biochemical reactions, including the methylation of catecholamines. Its antidepressant efficacy has been studied in numerous randomized controlled trials with depressed adults in Europe and the United States. Meta-analyses consistently support a potential therapeutic role of parenteral and oral SAMI in depression. However, oral SAMI as an adjunct has not been studied in randomized, double-blind, placebo-controlled trials. The study by Papakostas and colleagues was conducted at a single center for over 6 weeks. The participants were patients with major depressive disorder who hadn't responded to adequate doses of serotonin reuptake inhibitors, given for at least 6 weeks. They were randomly assigned to either SAMI or placebo. The SAMI group got one 400 milligram pill twice a day. After 2 weeks, they got 2 pills twice a day. The placebo group received the same number of pills. There were 39 patients in the SAMI group and 34 in the placebo group. They all continued to take their established doses of antidepressants. The definition of response was based on scores on the Hamilton Depression Rating Scale, either a reduction of at least 50% or a final score of 7 or less. By this definition, the response rates were 36% for SAMI and 18% for placebo. The rates of remission, defined as a Hamilton score of 7 or less, were 26% for SAMI and 12% for placebo. Similar results were obtained with the CGI response measure. The differences in response and remission rates between groups were all significantly different. When the Hamilton and CGI scores were reviewed as continuous variables, the differences were in the same direction, but they didn't reach statistical significance. SAMI was relatively well tolerated compared with placebo. The rates of study discontinuation due to intolerance were similar in the two groups, 5% for SAMI versus 9% for placebo. No serious adverse events were reported, but the patients taking SAMI had significantly greater increases in supine systolic blood pressure. In an editorial, J. Craig Nelson calls the data persuasive and says that demonstration of a new treatment for depression with a novel mechanism is exciting news. He reviews the modest literature on SAMI as monotherapy for depression and its possible mechanism of action. It acts as a major methyl donor for the synthesis of brain amines and the maintenance of phospholipid cell membrane. Low levels of SAMI have been reported in the cerebrospinal fluid of severely depressed patients. Oral and parenteral administration of SAMI results in a rise in CSF concentrations, indicating that the compound crosses the blood-brain barrier. An increase in SAMI levels has been positively correlated with improvement in depression, and concentrations also appear to rise in patients who respond to other antidepressants, such as dizipramine. SAMI is produced in the 1-carbon cycle involving folate, homocysteine, and vitamin B12, and abnormalities of each of these compounds has been associated with depression. In short, the hypothesis is that abnormalities in the 1-carbon cycle may result in low concentrations of SAMI, which in turn may limit the synthesis of brain neurotransmitters such as serotonin, norepinephrine, and dopamine. This may directly contribute to depressive symptoms, or it may interfere with or limit the action of other antidepressants. Ironically, this naturally occurring compound has been difficult to synthesize in a stable oral form with predictable dissolution. As a result, most initial studies gave the drug parenterally. A stable oral salt formulation was developed, and 4 placebo-controlled trials of oral SAMI in major depressive disorder were conducted between 1990 and 1993. However, the FDA then terminated trials in the U.S. because of concerns regarding the dissolution of the oral tablets. In 1999, SAMI became available again as an over-the-counter enteric-coated dietary supplement. The FDA doesn't routinely test the constituents of supplements, but in 2000, an independent laboratory tested SAMI products on the market and found that half of them contained significantly less of the compound than they claimed. In 2007, testing was repeated, and 11 products were found to contain the claimed weight and had the recommended dissolution characteristics. The report noted that the milligram dose in some cases was based on the weight of the salt rather than the active SAMI moiety. For example, 200 milligrams of SAMI tosylate disulfate contains about 100 milligrams of SAMI. Apparently, this is a situation of let the buyer beware. In addition, SAMI is relatively expensive. a local store in a national chain sells 36 400 milligram tablets for $43. A monthly supply of 1,600 milligrams per day would cost about $143. SAMI isn't covered by insurance, and these prices are considerably higher than usual copays. To date, SAMI appears to be well tolerated. It does carry the warning that it may induce mania in bipolar patients, but this is a characteristic of most antidepressants and in fact might indicate antidepressant activity. While SAMI has been studied for more than 30 years, most studies of major depressive disorder have focused on acute treatment. Data on long-term safety in major depression are limited, and the effects of long-term SAMI on the one-carbon cycle aren't well established. On the other hand, SAMI may also have beneficial effects on pain due to osteoarthritis and on some liver conditions. The usual doses of SAMI in major depressive disorder have been between 800 and 1,600 milligrams a day. Optimal doses and a safe upper limit haven't been determined. An early study suggested that there are sex differences in the time to peak plasma concentrations and that women have higher peak concentrations. This trial needs to be replicated, and there are numerous questions about long-term safety and efficacy, how SAMI compares with other adjunctive agents, and which patients are appropriate. However, SAMI offers a novel mechanism of treatment action and opens up a new area for future exploration. This wraps up our audio highlights of the August issue of the American Journal of Psychiatry. Please visit our website, ajp.psychiatryonline.org, for the complete versions of these and other articles, including author affiliations and financial disclosures. We also welcome comments about our audio digest. They can be emailed to Jane Weaver. Her email address is jweaver@psych.org. Next month, our audio will highlight prenatal and neonatal brain structure in children at high risk for schizophrenia, prediction of psychosis by negative and disorganized symptoms in adolescents and young adults, perineoplastic illness presenting as a mental disorder, and the role of histamine-related genes in the effects of food additives on children's ADHD symptoms. We hope you'll join us. Thank you.